for joining for the fourth session of the weekly Yale Cancer Center 2023 post-ASH CME review. Today we'll be going over lymphoma, and I'm Scott Huntington, one of the lymphoma specialists here, and I had the distinct pleasure of introducing our three presenters today. Our first presenter is Francesca Montanari, who will be presenting on indolent lymphomas. Dr. Shalin Kothari will go next and present aggressive B-cell lymphomas. And then Dr. Tarsheen Sethi will be presenting T-cell lymphomas and Hodgkin lymphoma. The rest of the lymphoma group is pictured here, including Dr. Sethi and Dr. Foss, who see lymphoma but also do cellular therapeutics. And then Dr. Seropian is really fixed in terms of his clinical practice on cellular therapeutics. But this is the broad group here, including Dr. Montanari, who sees patients at Smilo Greenwich. So I think we'll move to the remainder of the presentation. If there's additional questions that you have, please use the chat feature or question and answer. And we hope to have about a 10-minute discussion at the end of this presentation. Ooh, Dr. Montanari, mute. Those things happen.
Sorry about that. I'll start sharing with you my selection of abstract of indolent lymphomas. I have no conflict of interest to disclose. This is my abstract selection. We'll space from first line, second line, bispecific antibodies, single agent and in combination, and ultimately we'll review a new model for prognostication. So the first abstract I've selected is the long-term follow-up of an international randomized phase 3 study of rituximab versus watch and wait approach in patients with asymptomatic low tumor burden follicular lymphoma. Our current approach in this patient's population is watch and wait, based primarily on data on the pre-rituximab area that didn't show any benefit in early treatment. This study, earlier analysis, led to the approval of rituximab induction in this patient population in the UK. And here is presented the long-term follow-up analysis with a median follow-up of 12.6 years. Here's the schema of the trial. Patients 18 years or older within 3 months of the diagnosis with a grade 1-3A follicular lymphoma and early stage from 2 to 4 with no organ dysfunction and no symptoms and low burden of disease. We're randomized to receive either a watch and wait approach, rituximab induction, which consisted in rituximab weekly times 4, or rituximab induction plus maintenance for up to 2 years. And the follow-up, they were monitored with the serial imaging. Primary endpoint, time to initiation of a new treatment and quality of life. In this update, with a median follow-up duration of 12.7 years, the median time to initiation of first-line treatment was 2.7 years for patients in the watch and wait approach compared to almost 10 years in patients with a rituximab induction and not reached for patients with rituximab induction plus maintenance. Time from randomization to second treatment was similarly no difference between the three arms. In terms of overall survival, there was no difference in the overall survival between the three groups. Median overall survival was not reached in the watch and wait and rituximab maintenance group, and was 17.4 years in the rituximab induction. 20% of the 20% patients that died on average on each arm, 10% of the deaths were attributed to the lymphoma. In terms of high-grade transformation and time to second malignancy, again, no difference between the three groups, with about 20% events of high-grade transformation in each arm and 20% of secondary malignancy in each group. So the other conclusions are that early rituximab treatment should be considered a standard option in patients with low tumor burden asymptomatic follicular lymphoma, given the significant advantage in time to new treatment and no detrimental effect on high-grade transformation rates, secondary primary malignancy, and the previously reported improvement in quality of life measures. Is this practice changing? I think this is a very valuable data set that will provide us a little bit more flexibility to better individualize treatment based on patients' preferences. I find very, very reassuring that a quarter of patients in the watch and wait arm at 12.7 years of follow-up never required any treatment. So I think that this trial also reinforces our approach of watch and wait strategy in these patients. But it's also good to know that it's not detrimental to start rituximab in those patients who, for life preference, decide to be more on control of their disease. Second abstract I've selected is a 5-year overall, 5-year results and overall survival update from the phase 3 AUGMENT trial, lenalidomide plus rituximab versus rituximab plus placebo in patients with relapsed refractory indolent non-Hodgkin lymphoma. As we all know, the AUGMENT study, the R-squared demonstrated superior efficacy compared to rituximab placebo in patients with relapsed refractory non-Hodgkin lymphoma, leading to the approval of this combination in previously treated follicular and marginal zone lymphoma when the initial analysis was published in 2019. Just reminding the schema of the trial: patient that with a follicular lymphoma grade 1 to 3A or marginal zone lymphoma that had received 1 prior line of systemic treatment and documented relapsed refractory disease, but not refractory to rituximab, were stratified and randomized to lenalidomide rituximab, as it is currently approved for with the lenalidomide for 1 full year of treatment, and rituximab given during the first 5 cycles, only for the first 5 cycles. And rituximab placebo was given similarly. Primary endpoint being PFS, secondary endpoints including overall survival. And with the additional follow-up provided with this update at a median follow-up of 65.7 months, median PFS continued to favor the R-square group, 27.6 months versus 14.3 months in the R placebo group. Time to the next lymphoma treatment, which is a more subjective kind of measure, because time to initiation in treatment in lymphoma is not as standardized, was continued to favor the R-square, 73.1 months versus 13.8 months for R placebo. And with fewer patients in the R-square arm receiving more than 1 subsequent lines of treatment. And I think this was the most important, the most relevant data that with the overall survival analysis, with this median follow-up extension, the 2 curves remain, continues to separate. Although the median overall survival was not reached in either arm, there was an improvement in the overall survival in the R-square compared to the R placebo. Hazard ratio was 0.59 and P significantly, statistically significant. There were no new treatment emergent AEs reported in this update. These came from the original analysis, so not surprisingly, there were more toxicity on the R-square group compared to the R placebo, and especially with the most common being neutropenia. But in the long term, there was no signal that was worrisome for an increase in the risk of secondary primary malignancies due to lenalidomide exposure or histologic transformation. So I think that these updated results further support the use of this combination in the relapsed refractory setting. Moving forward, I'd like to review data on the CD20, CD3 bispecific antibodies. This was a very big and very popular topic at this year ASH meeting. This antibody, as we all know, binds CD20 on malignant cell, CD3 on T cell, eliciting T cell mediated toxicity. We will review here the efficacy and safety data on mosunetuzumab, on odronextamab, and the combination of epcoritamab with R-square. I just want to highlight here that mosunetuzumab, after these data were presented at the ASH meeting very earlier this year, received accelerated approval for follicular lymphoma, who had received at least 2 prior lines of treatment, including an anti-CD20 antibody and an alkylating agent. Odronextamab, also very promising results we're going to review, has been granted fast track designation by the FDA for follicular lymphoma. So here the update on the pivotal phase 2 study on mosunetuzumab monotherapy in patients with relapsed refractory lymphoma. Key inclusion criteria included patients with follicular lymphoma grade 1 to 3A with a good performance status with more than 2 prior lines of treatment. The bispecific antibody was given intravenously with a step-up dosing in cycle 1. That is usually a strategy to mitigate the risk of CRS that is unique to this group of drugs. And then subsequent to the step-up dosing was given day 1 of every cycle. 60 milligrams with cycle 2 down to 30 with the cycle 3 on. It was a fixed duration treatment. Patients achieving a CR after 8 cycles stop treatment and were allowed to be retreated should the recurrence. Patient achieving a stable disease or a partial remission continued on the treatment for 17 cycles. There were no mandatory hospitalization, and the study met its primary endpoint of efficacy at the prior published initial analysis with a CR rate of 60% in patients that compared to 14% of historical control. And here it was provided an updated efficacy and safety analysis with a longer follow-up, 10 months longer than the original analysis. Baseline characteristics, I just want to highlight here. These were very, very heavily pretreated patients. Patients up to the age of 90 were included in the study. And there were a significant proportion of what we call POD24, which are very, very high risk patients that usually have a worse outcome. These analyses, there was no difference in the reported efficacy compared to the prior analysis, with an overall response rate of almost 80% and a CR rate of 60%. Very quick time to first respond, 1.4 months, and 3 months for the time to the CR. I think what is more meaningful about this update is that the duration of these responses and the benefit appear to be very impressive, especially when compared to the benefit achieved with the prior line of treatment before mosunetuzumab in these patients. As we see here, the blue line is mosunetuzumab, prior treatment is in red, median duration of complete response not reached for mosunetuzumab, 15 months for prior treatment, and PFS is similarly favoring, like mosunetuzumab was 24 months compared to 12 months for a prior line of treatment. And I think this is very important because breaks sort of the vicious cycle in patients with follicular lymphoma with subsequent lines of treatment. Usually the duration of response is half of the prior one. In terms of safety profile, there was not an update on the AEs reported in the original analysis, and most of the adverse events not related to CRS were grade 3 and grade 4 were essentially neutropenia and hypophosphatemia, which appear to be manageable. And also in terms of CRS, most of the CRS were predictable after the first dose and after the first full dose of the antibody. Mostly grade 1 and grade 2. There was only a grade 3, and a grade 4 was in a patient that apparently had a leukemic form of follicular lymphoma with a very high white count, so had really high risk features. Again, this is, I think, practice changing. After the FDA approved this drug in the 3rd-line setting, we have now a new option, and it's very exciting, and it's probably going to be in direct competition with CAR T-cell in this space. I just want to highlight here a poster presentation that, as oftentimes happens when a drug shows such an amazing activity in patients that are heavily pretreated and in a subsequent line of treatment, it is tested earlier in the course of the treatment and in combination with approved treatment. And we have currently open here at Yale, under the lead of Dr. Huntington, clinical trial Here's in collaboration with Brown University. This is mosunetuzumab with a lenalidomide augmentation as first-line therapy for follicular and marginal zone lymphoma. In this clinical trial, patients with untreated follicular and marginal zone lymphoma in need of treatment will be treated with mosunetuzumab. As we reviewed previously, the same schedule is going to be given, though subcutaneously. After 4th cycle, patients in CR will continue for a total of 8 cycles. Patient not achieving a CR, so with a partial response of stable disease, will go on receiving an augmentation with lenalidomide to complete 8 cycles. And then there is provision for an extended augmentation if no CR is achieved after cycle 8. Primary endpoints of the studies are overall response rate, CR rate, and PFS. And there are correlative studies looking at the tumor microenvironment, CT circulating DNA, and MRD. Moving forward, the other very promising bispecific antibody that was presented at the ASH meeting in follicular lymphoma is odronextamab. I'll be very quick here because it's essentially the data are similar to the one that we have reviewed with mosunetuzumab, although the follow-up was much shorter. It is given with a step-up dosing that was changed in the course of the study to further mitigate the risk of CRS. And so it was a little bit more in day 1 and day 2, day 8 and 9, 15 and 16 of cycle 1, escalated to the full dose only with cycle 2. And the way that this bispecific antibody was given as a sort of maintenance continuous treatment every 2 weeks. Again, here we see similar response rate than we have seen with mosunetuzumab, a very high overall response rate of over 80% and a complete response rate 75%. Median opportunity of follow-up has been 22.4 months. And in terms of safety profile, again, similar to mosunetuzumab, neutropenia was a big adverse event besides CRS. And CRS risk were mostly grade 1 and grade 2, especially after the optimization of the step-up regimen. Grade 3 became much less frequent. And just to remind what is a big deal at grade 3, CRS is that would demand high-grade oxygen and vasopressor support. Finally, I'd like to review this study, the subcutaneous combination of epcoritamab with rituximab and lenalidomide in patients with relapsed or refractory follicular lymphoma. So a bispecific antibody in combination with an approved chemoimmunotherapy. These were patients with follicular lymphoma, relapsed refractory, in need for treatment. There were included high-risk patient. Epcoritamab was given subcutaneously and was given in combination with rituximab and lenalidomide following the augment schema. Treatment lasted 2 years. Primary objective was a safety and anti-tumor activity. Treatment emergent adverse event as expected based on the R-square toxicity profile. I think the study was impacted by the fact that it was conducted during the COVID-19 pandemic, with many patients contracting the COVID-19 illness. CRS event, very minimal, very encouraging these results, and mostly grade 1 and grade 2, no grade 3 CRS was recorded. And overall response rate 95% with a complete metabolic response of 80%. So based on these very exciting results, there is currently a phase 3 trial of subcutaneous epcoritamab in combination with R-square versus R-square among patients with relapsed refractory follicular lymphoma that is ongoing. I'd like to close my selection of abstract with this abstract on prognostication. This is a very important and area of clinical unmet need for follicular lymphoma. We know that patients of follicular lymphoma is very heterogeneous, with the patient doing well on the watch and wait approach for more than 12 years, and patients instead relapsing with their disease within 24 months from initiation of chemoimmunotherapy. And those are really the patients that we really need to do more research and develop new treatment paradigm for, because these are the patients that have the more challenging prognosis. So in this study, it is presented a new prognostic model called FLIPI-24. And this model was specifically developed to predict the risk of disease progression within 24 months from starting the first line of chemoimmunotherapy. So we have no current tool to identify these patients, and having the ability of identifying these POD24 patients earlier will help direct clinical trials and novel therapy. So this FLIPI-24 model uses 5 linear variables: age, LDH, hemoglobin, WBC, and beta-2 microglobulin, which are very easily, which are common variables that we have available for all our patients. And based on these 5 linear variables, it divides patient risks, patients in 5 risk group. The low risk group has less than 10% chances of developing a POD to progress within 24 months from the initial treatment, versus the very high risk has very high, more than 40% chance of progressing. And therefore, I think that this model will provide a good platform for future models, and incorporating maybe other information. Total metabolic tumor volume seems to be an emerging important independent predictors for response, especially in CAR-T. We don't have a lot of data about that in bispecific antibodies so far, but I think this was a good start. So in summary, we have reviewed the data that showed that the rituximab induction plus or minus maintenance appears to be non-inferior, non-detrimental alternative to watch and wait for selected patients with a symptomatic low tumor burden follicular lymphoma. 5-year follow-up of lenalidomide rituximab continues to show a PFS and an overall survival benefit compared to placebo with rituximab. CD20, CD3 bispecific antibody demonstrated durable efficacy with manageable toxicity in high-risk patients with follicular lymphoma, and mosunetuzumab has now received the accelerated FDA approval in patients with follicular lymphoma in the third-line setting. There are ongoing clinical trials that are evaluating bispecific earlier in the lines of treatment and in combination with approved treatments. And the identification of diagnosis of POD24 patients is a very important clinical unmet need. This new FLIPI-24 model proposed by Mayo Clinic and emerging data on a total metabolic tumor burden hopefully will help us prognosticate better this subset of patients. And with this, I'm gonna stop sharing my presentation. I'm gonna let Dr. Shalin Kothari take over and discuss mantle cell and aggressive lymphomas. And I'm happy to take any question at the end of the presentation.
Ouch. 1 second. Okay. Can you see my screen?
We see your PowerPoint. You want to, yeah, perfect. Slideshow, if you want to go to. Ooh. Perfect.
So I'm going to focus mainly on large B-cell lymphomas, mainly aggressive B-cell lymphomas and mantle cell lymphoma. I have no relevant conflict of interest to disclose for this presentation. The first abstract I chose was a biomarker-driven treatment strategy in high-risk large B-cell lymphoma, the final results of a Nordic phase 2 study. This study included patients from 18 to 65 years of age, histologically confirmed CD20 positive DLBCL, including high-grade B-cell lymphomas and follicular 3B. They had to have at least stage 2 with an age-adjusted IPI score of 2 to 3, with more than one extranodal site of disease, testicular lymphoma, and paranasal sinus and orbital lymphoma with the destruction of the bone. And these are the clinical characteristics, which are not too relevant to our discussion, but to kind of point out major pointers here, that there were a significant portion of patients with DLBCL NOS, with double hit and triple hit lymphomas and high risk biological characteristics. The way this study was run was patients were allowed to get some pre-phase therapy if required. They received 2 cycles of R-CHOP, followed by interim staging, and they were stratified based on these biological risk factors. So if they had one of these risk factors positive, then they were escalated to receive dose-adjusted EPOC for 4 cycles, followed by rituximab with high-dose Ara-C, with final staging via a PET scan. If their biological factors were negative, then instead of infusional strategy, R-CHOEP was given for 4 cycles, and then they were off study. And the biological risk factors included are all clinically relevant, something that we always do in the clinic. So single MYC rearrangement, DHL, double-hit lymphoma, or double expressor lymphoma, P53 positive by IHC, or P53 deletion, and CD5 positivity. And these are the PFS curves. So you can see that with this escalated strategy, they were able to improve overall outcomes for biologically high risk large B-cell lymphomas with PFS close to and statistically insignificant to biologically low risk disease. And if I were to further stratify, high-grade B-cell lymphoma with double-hit disease had a similar PFS as biologically as some patients with no double-hit lymphoma. Where this strategy did not fare well is in patients with TP53 deletion, where I think we still need to figure out better strategies and more novel strategies such as CAR T-cell therapy and bispecific antibodies might be more helpful in upfront strategies for TP53 aberrated disease. The next study I wanted to focus on is abstract 735, 5-year survival results from remodel trial, which showed improved outcomes in DLBCL molecular subgroups from addition of bortezomib to R-CHOP chemoimmunotherapy. The study aim was based off some preliminary preclinical data that bortezomib and in general proteasome inhibitors would have, there was a signal in the preclinical world for better outcomes with ABC DLBCL models. So the study design was patients who had advanced stage DLBCL. They were consented, eventually received first cycle of R-CHOP. While they were receiving that cycle, a biopsy was sent for molecular profiling, and mainly it was gene expression profiling platform. And then they were stratified based on molecular phenotype and IPI score. And they were randomized to receive 5 more cycles of R-CHOP with bortezomib or 5 cycles of R-CHOP alone. Important to point out here that there was an amendment where the dose of bortezomib was increased from 1.3 to 1.6 in the middle of the trial. There was interim analysis which showed that the benefit was mainly in the ABC phenotype, and hence they adjusted some of their parameters, analysis parameters based on that. And this is the distribution of patients. It was nicely balanced between the 2 groups and between the 2 treatment modalities. And these are the results. So you can see that there's a clear difference and statistically significant PFS and OS benefit in ABC DLBCL in contrast to GCB DLBCL. Molecular high risk group was a subgroup that they had defined. It was a predefined subgroup based on multiple different parameters put together as part of the gene expression profiling. And that group also showed statistically significant difference in PFS with addition of bortezomib to R-CHOP. The next study I wanted to focus on is a prognostic index called LAB-PI in DLBCL, validation study on behalf of the Spanish Lymphoma Cooperative Group. So here I'm showing all these different prognostic variables that we sometimes use in the clinic But mainly we rely, as we all know, on our IPI and RIPI. These authors designed a prognostic parameters which are much easier to do, cheaper to do, and more easily available in developing countries. So the three parameters included high LDH, anemia of less than 12 in men and 13.5 in females, high beta-2 microglobulin and 2 points for high beta-2 microglobulin more than 4 milligram per liter. What the authors go to an extensive length to show that this particular index is predictive and prognostic, but I'm just showing the EFS and OS curves here. And they nicely correlate with the IPI score that we use commonly based on stratification, based on the points of 0, 1 to 2, 3, and 4. Which corresponds to low, intermediate, high, intermediate, and high IPI scores. The next abstract that I wanted to focus on is polatuzumab vedotin combined with rice or R-ICE as second-line therapy in relapsed refractory DLBCL. So as we know, the current standard of care in relapsed refractory DLBCL relapsing more than 1 year, so not primary refractory, after first-line treatment is salvage treatment followed by autologous stem cell transplantation. So the hypothesis for this study was that polatuzumab vedotin combined with rice salvage chemotherapy as first salvage treatment would be safe and effective bridge to autologous stem cell transplant. The inclusion criteria was pretty broad. Adult patients with a performance status of 0 to 2 with relapsed refractory disease after first-line therapy that must have included anthracycline. It also included transformed DLBCL, PMBCLs, and high-grade B-cell lymphomas. And they, of course, had to be transplant eligible. And this is the patient characteristic table. And it's important to note that there were equal distribution between primary refractory disease and relapse disease. Most patients were at stage 4 or 3 at advanced stage at relapse. And 78% of these patients had received R-CHOP and 22% had received R-EPOCH. And 17% of patients were double hit lymphoma and 34% were double expressor lymphoma. And something important to note out is that transformed lymphomas was a pretty significant representation with almost 30% of patients. The way this salvage therapy was given was at dose level 1. Basically, it was rice therapy in addition to polatuzumab vedotin given on day 1 at 1.8 milligram per kilogram. And then once patients had received autologous stem cell transplantation after 2 to 3 cycles of pola rice, they would be eligible for polatuzumab consolidation of 3 to 4 cycles, given every 21 days for a total of 6 cycles. And these are the results. So you can see that a total of 41 patients were evaluated, and 22 patients were able to get stem cell transplantation. So the authors did note that this is definitely a low percentage, and there is possibly a signal that polatuzumab vedotin may potentially cause problems with stem cell mobilization, but that needs to be studied further. But what is important to note here is the PFS and OS curves, which are very encouraging in otherwise a very heavily pretreated, more biologically high risk patient subgroup. So here I show primary refractory patients and relapse disease. So clearly polarized regimen is not an effective second-line therapy for somebody with primary refractory disease, but for relapse disease, the PFS curves look very encouraging. And this is the overall survival curve with the time to median follow-up is still pretty low, so we need to look at this data with more mature follow-up in upcoming years. but the overall survival curves look very encouraging in spite of many patients not receiving stem cell transplantation after Polarize. The next abstract I wanted to focus on is Tafalen in relapsed refractory large B-cell lymphoma, real-world outcomes in a multi-center retrospective study. This is in contrast to the L-MIND trial, and the authors go at an extensive length to compare the L-MIND eligibility criteria and how Tafalen is currently being used in the clinic. And what these tables really show here is that in the real world, only 11% of patients would have technically been eligible for L-MIND. And hence, they wanted to see whether this difference in real world versus the trial data, does that lead to any change in outcomes? And as we know, the reason this is a pertinent question is because in 2020, FDA gave an accelerated approval to Tafalen in patients with relapsed refractory DLBCL, including transformed DLBCL who are not eligible for autologous stem cell transplantation. So these are the curves with median PFS of 2.1 months and median OS of 7 months. So clearly, it leaves a lot desired, and these data don't correspond with the trial data. Mainly, authors conclude because of its use in the real world, which is not in congruence with the patient population that was studied in L-MIND. So I think this study is a good reminder to look at patient population for these trials and make sure that we are using this clinical option in an appropriate setting. The next abstract I wanted to focus on is the abstract number 555, risk of CNS involvement in high-grade B-cell lymphoma with MYC and BCL2 rearrangements, analysis of a population-based cohort with routine FISH testing in British Columbia. So as we have discussed in previous CMEs, there is a flurry of data coming out, although albeit all retrospective, but with very high numbers, with high confidence, that we don't necessarily have good effective strategies for CNS prophylaxis. And this particular study is focused mainly in high-grade B-cell lymphomas. So they have these two subgroups based on pre-FISH, so the present subgroup is what they call where prospectively the FISH testing was done, and the historic subgroup is where they had to do retrospective FISH because from 2005 to 2010, it was not standard of care at that center. And as you can see here, patients, these are all with high-risk disease, and CNS prophylaxis was given in this fashion. So 40% did not get any CNS prophylaxis, intrathecal therapy for 51% in the present subgroup, and 9% with intravenous prophylaxis. So the authors show that the risk for CNS relapse for this high-risk or high-grade B-cell lymphoma is around 6%, which is clearly a significant percentage and higher than more low-risk DLBCLs. They show that CNS IPI scoring is still relevant in this current era, even in high-grade B-cell lymphomas, and the high CNS IPI score is able to identify patients who are at a high risk for CNS relapse. But then when we look at all patients in this subgroup, in this study, whether they received CNS prophylaxis or not, it really didn't change the cumulative incidence of CNS relapse. And even when looked into the subpopulation of high CNS IPI score patients, we still did not see any difference between patients who received CNS prophylaxis versus who didn't. And of course, I wouldn't make too much of this particular curve of CNS prophylaxis by modality of treatment, but clearly goes to show that the common perception that intravenous therapy is potentially a better strategy is probably not true. and we need more trials to identify more effective CNS prophylaxis regimens. Next, and my last abstract for this meeting is abstract number 1, which was a plenary session paper, which is the efficacy and safety of ibrutinib combined with standard first-line treatment or as substitute for autologous stem cell transplantation in younger patients with mantle cell lymphoma. Results from the randomized triangle trial by the European MCL network. This particular trial included MCL patients who were previously untreated with stage 2 through 4 disease, who were younger than 66 years of age, and of course they were suitable for transplant and high-dose chemotherapy with ECOG performance status of 0 through 2. The primary outcome being failure-free survival. So it's important to understand how the trial was designed between the 3 arms. So arm A is, so in all the 3 arms, the backbone of chemotherapy was anthracycline containing and cytarabine containing regimen, R-CHOP, R-DHAP, alternating for a total of 3 cycles each. And then the difference between the 2 arms is based on whether the patients received autologous stem cell transplant or versus patients who did not receive autologous stem cell transplant and only received 2 years of ibrutinib maintenance. The first arm did not receive ibrutinib along with the R-CHOP, R-DHAP, versus these 2 arms received ibrutinib as part of the chemo regimen itself. And important to note, which is talked about less when we talk about this trial, is that our maintenance was added following national guidelines in all 3 trial arms. So many patients, actually almost half of the patients in each arm, received rituximab maintenance, which is currently what we use in clinic. So I would say that in all these arms, especially in these 2 arms, it was R plus I maintenance for the most part. These are the patient characteristics. So I just wanted to point out that most patients were stage 4, approximately almost 90% in these 3 arms. And 58% of patients were low MIPI, around 30% were intermediate, and 15 to 16% of high MIPI patients were included in this trial. These are the important curves out of this plenary session paper of failure-free survival. And you can see that the arm where patients received R-CHOP, R-DHAP, followed by autologous stem cell transplantation, had an inferior failure-free survival in contrast to ibrutinib-containing arms. Now, we need more time before we can tease those 2 curves out, but clearly we can say that addition of ibrutinib makes autologous stem cell transplant less relevant in the frontline setting. So that's pretty much the takeaway out of this study. And that difference between overall survival of ibrutinib-containing arms versus non-ibrutinib containing arms is clear. So the authors conclude that it's overall too early to evaluate statistical significance of overall survival. But there is definitely a very clear signal that ibrutinib containing regimen, we may be able to avoid autologous stem cell transplant consolidation in those patients as long as they are able to receive ibrutinib maintenance with or without rituximab. So authors conclude that A plus I arm is superior to A. The autologous stem cell transplant is not superior to ibrutinib-containing regimens, and currently no decision whether autologous stem cell transplant adds to ibrutinib, but toxicity favors ibrutinib only. And numerical overall survival benefit was seen in the ibrutinib arms. So this is my summary slide for mantle cell lymphoma and large B-cell lymphoma. R-CHOP, R-DHAP with ibrutinib, followed by ibrutinib with or without rituximab maintenance is an effective frontline strategy in young and fit MCL patients. Autologous stem cell transplant could be safely avoided with this strategy. clinically available biomarker-driven strategy to escalate traditional immunochemotherapy could potentially help improve outcomes in high-risk large B-cell lymphoma. Addition of bortezomib to R-CHOP shows improved outcomes in ABC subtype of DLBCL. In my opinion, it would have been practice-changing if gene expression profiling was readily available clinically, which is not the case at this time. Lab PI prognostic model, which includes LDH anemia and beta-2 microglobulin, is a cheap, reproducible, and effective tool that could be useful in some countries and in some clinical settings. Pola-Rice followed by autologous stem cell transplant consolidation is an effective second-line regimen with good outcomes. This off-label regimen can be potentially considered in patients with transformed DLBCL who would not have otherwise received Pola in the frontline setting. Tafa-Len may be optimally suited only for patients with fewer prior lines of therapy and non-refractory disease, so that it reflects L-MIND clinical trial population. And lastly, currently utilized strategies for CNS prophylaxis in high-grade B-cell lymphomas are ineffective and more studies are needed. Thank you so much. And now I'll pass on to Dr. Sethi to drive us home.
Thank you, Dr. Kothari, for the excellent presentation. So let me just, can you see my screen?
We can see your PowerPoint. Yeah, you can just share your slides. Or slideshow.
Okay, here we go. All right.
Perfect.
Okay, thank you. All right, so I will be focusing on T-cell lymphoma and Hodgkin lymphomas. So for the T-cell lymphoma abstracts, as well as for the Hodgkin lymphoma abstracts, my selection is most focusing on immunotherapies, in both the diseases. So starting with the first abstract, it's a phase 1 trial using nivolumab in combination with dose-adjusted EPOCH in newly diagnosed PTCL. This was an investigator-initiated study by Dr. Havikas at University of Colorado. So we know that dose-adjusted EPOCH is a viable treatment option in the first line for peripheral T-cell lymphomas, regardless of subtype. However, we also know that with anthracycline-based therapies, 25% of the 5-year PFS in PTCL is just 25%. So there's a great need to improve upon these anthracycline-based regimens in the first line. The issue with immune checkpoint blockade in T-cell lymphomas is that there has been a risk of hyperprogression noted in certain subtypes, like specifically ATLL. Single-agent immune checkpoint inhibitors had an overall response rate of 30% in heavily pretreated patients. But again, single-agent therapy in T-cell lymphomas is not really the way forward because of the risk of hyperprogression. So this particular study wanted to look at the combination of cytotoxic therapy and immune checkpoint inhibition in the hope that the tissue injury from chemotherapy will result in new antigen expression and increased tumor immunogenicity. So also in PTCLs, the and we need more treatment options. And the other thing is that with the immunosuppressive microenvironment and high mutational burden, there is a risk, there is a viable reason why this would be effective. So we looked at the combination of nivolumab and EPOCH in the study, and they used a flat dose of nivolumab and the standard dosing of dose-adjusted EPOCH. And they allowed dose level starting at dose level -1. So here, the main thing I want to focus on is that they included a number of different subtypes, also including primary cutaneous gamma delta T-cell lymphoma. It is an uncommon rare subtype. However, This is something we do come across in clinical practice, and I'm highlighting that because they found some durable responses in this population. So as expected, patients did have a number of immune-related side effects, and here at least one patient had each one of these that you can see in this figure. What they found was that the immune-related side effects occurred early, and that they did lead to stopping nivolumab in these, in a subset of these patients because of the immune-related side effects. What was really interesting was, since the study did allow a previous cycle of chemotherapy, what they found was that the patients who had previously received chemotherapy and where the combination was initiated as cycle 2 rather than cycle 1, these patients had very few immune-related side effects and treatment discontinuations. So this strategy did somehow it was like it was not really a planned thing. It was just because these patients ended up starting with cycle 2 that they did find fewer immune-related side effects. So a potential strategy for future studies. What they also saw was that even though the toxicity was seen early, but number of patients with both PR as well as stable disease did convert into a CR at the end of treatment. So necessarily the treatment was not, the treatment as it was continued, late responses were seen. Here's the survival analysis curves. So at a median follow-up of about 2 years, the median progression-free survival was 434 days, and the overall survival was 714 days. They did not find any obvious predictor of outcome, so including nothing on the NGS panel or PD-1, PD-L1 expression. So there were no clear markers of predictive of response. So basically, the things that they highlighted was that in this particular scenario, there were no hyperprogression events, which is reassuring, considering that single agent checkpoint inhibition is really something that we worry about. Immune-related side effects did occur early, and then, as I mentioned, people who had prior chemotherapy did do better in terms of tolerability of nivolumab. Also, there were at least 2 patients who had durable responses in gamma delta T-cell lymphoma, which is traditionally thought to be very aggressive. And so that, again, is, I think, one of the reasons that, checkpoint blockade is still being investigated in T-cell lymphomas, in the hope of, finding particular disease subtypes that would respond. So the next paper, again, is also an immune checkpoint based combination, and this one combines pembrolizumab and romidepsin. The prior study was in the frontline. This is in relapsed refractory T-cell lymphoma, and this is a study out of MD Anderson. So basically, again, as we mentioned, there is even though there is a risk of hyperprogression, there is still reason to study immune checkpoint inhibitors in T-cell lymphomas. And in this particular scenario, they wanted to combine it with an epigenetic modifier, that is romidepsin, which is an HDAC inhibitor. There is preclinical data for possible synergy. That's because HDAC inhibitors do increase PD-L1 expression. And so they think that they can, the addition of checkpoint inhibitor will promote, will basically in these patients can help with improved responses. So in this study design, they had a phase 1 lead-in for 6 patients as a safety cohort, and then they went ahead with the phase 2 cohort. And romidepsin is traditionally given day 1, 8, 15. In this particular study, it was given only on day 1 and day 8. I just here want to highlight that they did include a subset of patients that had TFH histology like AITL, which traditionally, and this subset of patients usually responds well to romidepsin. Again, they did have 2 patients who had hyperprogression, in this particular case. So that is, but again, it was a minority of patients when considering, that seen with single agent versus combination of checkpoint inhibition. Their overall response rate was 47% with a CR rate of 37%. Again, this was a heavily treated population, so these are not unexpected numbers. And this is a Sankey plot that just shows that, as you can see here, the TFH histologies, many of them did respond and get CR after getting pembrolizumab, but the response is not as uniform in some of the other subtypes. So the median overall survival in this cohort of patients was 21 months, and the median PFS was 4.8 months with a median duration of response of 36 months. So basically what they found was that even though by absolute numbers it may not seem high, but for T-cell lymphomas in this scenario, it did lead to meaningful response with high response rates. And so they have a larger phase 2 study based on this as the next step. So the next study that I'd like to highlight was actually presented by Dr. Francine Foss. This is a registration trial for EQUAD-7, which is an improved formulation of denileukin difitox, which is on TAC. And this included patients of relapsed refractory CTCL. So ONTAC is a recombinant protein that has diphtheria toxin and human interleukin 2. ONTAC was previously taken off the market because of manufacturing issues in 2014. So this is an improved version of this. So basically, it has two different ways that it acts. There is direct tumor cytotoxicity by the IL-2 attacking the attaching to the tumor cells, and the diphtheria toxin acting as basically the active agent. And then it also affects the Tregs, in which EQUAD-7 actually decreases the number of Tregs. So it's being thought of as it is actually as an immunomodulatory agent. So in this particular case, we primarily included patients with CD5 positive, CD25 positive tumor with CTCL in relapsed refractory cases. So in terms of response rates, I just, it showed the response rate was kind of dependent on stage, and most of the responses was seen in early stage disease with an overall response rate of 36 to 45%. This just shows you, one of the things we assess disease response is M-SPOT with looking at the skin tumor burden. And here we see that the maximum, response again was seen in 48% patients, with 12% achieving CR. And this swimmer's plot is just delineating about 20% patients had prolonged responses of more than 1 year. The main side effects were expected side effects that are IL-2 related side effects like capillary leak syndrome and peripheral edema, as well as some transaminitis and infusion related reaction. So again, overall, this is an active agent in CTCL, and again, it is a possible improvement over ONTAC, and this was a registration study, and it has been the initial application is accepted for approval for review. So I think at this point, it's since it's 1 o'clock, I'm going to stop here. Basically the Hodgkin, cases that abstracts that I wanted to talk about were Nivo-ICE that was found to be pretty effective in high risk Hodgkin lymphoma patients. And the other one is a combination of a newer agent, an anti-LAG3 antibody with pembrolizumab. And but in the interest of time, I will stop here. Thanks.
So I wanted to thank all three of the panelists for really selecting highest priority and impact abstracts and doing a great job summarizing that. All panelists are able to stay for a few more minutes, and so I thought we'd have a little bit of question and answer period. Some great questions coming in from Dr. Nepoditi, but first I had a question for Dr. Montanari. With the augment long-term data and with really encouraging data with bispecifics, a lot of patients with follicular, the non-high-risk patients, are actually getting rituximab first line, R chemo, often Arbenda second line. And how do you think about third line for those patients? Do you think about R squared? Do you think about bispecific? How do you actually, without the data, we don't really have randomized data. How are you going to approach those cases, which will be actually quite common?
Very good question. And I think this is by just my personal opinion. I don't think we're gonna be given data on the sequential treatment, meaning what would be the outcome in patients receiving R squared as second line and the patients followed by bispecific. Most of the clinical trials that are now ongoing tend to combine R squared with or without the rituximab with the bispecific antibody. So, when we combine this treatment, we always get into a little bit more toxicity. And I'm not sure that all patients would benefit from an intensification of treatment earlier on. What we really need is a good prognostication model to really risk stratify this patient up front and guide us in the selection. But for now, I think I would be content to just sequence the treatment as they are available with R squared followed by a bispecific antibody. Certainly, after reviewing this data, CAR-T in my mind is pushed a little bit over in the future for this patient population.
Yeah, I think that's a really helpful response and exactly what I'm thinking as well. There may be some slight, select patient populations where you have toxicity concerns, whether it be renal dysfunction with lenalidomide, things like that. But the R squared data is quite compelling with that, particularly that freedom from next treatment of 70 months. So I think that sequence is here to stay, at least for the time being. There's an important question to all of us, but really directed to Dr. Kothari about where do we go with first line DLBCL in 2023? We'll likely hear about Pola R-CHP, but I thought your data actually of using R-CHOP and then EPOC and then giving some cytarabine was quite compelling for the high grade double hit patients. So how are you thinking about approaching your non-double hit and double hit patients in 2023?
Yeah, very difficult question to answer, mainly because we don't have direct data, but we can put few pieces together and come up with a treatment plan, I guess. So my strategy would be that if the patient is a de novo DLBCL with IPI score of 3 to 5, and it does not have double hit disease or double expressor disease, then I would still be more, a favor of Pola R-CHP. If it comes to a patient where we are worried about double expressor and double hit disease, I would think that, I would definitely put in a lot of weight to this dose escalation strategy, where there is incorporation of high dose methotrexate, there is incorporation of our EPOC, followed by high dose cytarabine. I think the data is very compelling, as you said. And I think Dr. Nepoditi also asked regarding how I would approach subgroups of these DLBCLs. And in this current time, so far, all the trials that were designed to primarily study these subgroups have been negative. So, for example, Phoenix trial, very compelling results when you further tease out these molecular subgroups. For example, in the Phoenix trial, MCD subgroup did phenomenally well when ibrutinib was added to R-CHOP. Similarly, the data that I presented of adding bortezomib to R-CHOP in ABC DLBCLs. But the reality is that in clinic, gene expression profiling is very challenging to do. And I think we really need to put in a lot of effort as a group of clinicians to have better clinical modalities to risk stratify patients by genetic makeup in the clinic. If not by diagnosis, then at least by the end of first cycle, so that we can change strategy second cycle onwards.
I think that's really helpful. And I guess that what you're getting at is a dynamic biomarker, whether it be cell-free DNA or kind of reduction of circulating disease. There's a question from the audience, kind of I think broadly, and Dr. Montanari kind of alluded to it, trying to think about bispecifics versus cellular therapy, CAR T. Tarsheen, can you help us with that thought? Right now, it's really just in follicular, but certainly there will be more data with bispecifics and large cell lymphoma. How do you kind of think about those modalities for your patients?
Yeah, I think right now it's such a dynamic field, and which we are thankful for to have all these different options. But I would think that CAR T cell therapy, I think, is definitely more involved. And also there's often a delay because there's still the options we have are not off the shelf options. So there's a delay in, getting these patients to treatment. So I think having the option of bispecifics really, I really don't think that one would replace the other. I really think that they're both important, but I think having the option of bispecifics as an off the shelf option will avoid the delays that we usually see, and then also would be reasonable options for maybe even older individuals that sometimes are not candidates for CAR T cell therapy.
Yeah, it's clear that bispecifics are being moved up earlier into first line. So follicular lymphoma for large cell lymphoma. I was reminded that it was 25-year anniversary of rituximab being approved. And to think about in the last 3 years, all the bispecifics being developed and how fast this is moving is pretty remarkable. So I'm sure we'll have lots of dense CME post-ASH meetings for the coming years as well. But I want to thank our presenters and thank all of you for joining. And I hope everyone has a great weekend. Thank you.